turn it over to Allison and Jackie very shortly. So this is the second installment of the webinar series. Welcome. Just a reminder, these will be taped, and you'll be able to, the patients who aren't able to attend or CanSOLVE members will be able to see them online. We'll let you know when it is posted. If you have questions during the session, you can enter it in the chat window or raise your hand. We'll have questions at the end. There'll be lots of time for questions. The presentations will be short. So there's going to be two projects presented today. Dr. Allison Dart and Jackie McKee are going to be presenting on the iCARE study, which they will tell us more about. And Dr. Scully Mahmood and Megan Murchie will be presenting from Toronto.
Just lost your audio.
Perfect. But they're all focusing on diabetes, and there's a pediatric slant to these. So Allison and Jackie, thank you so much. I'll turn it over to you.
Okay. We'll actually turn it over to Jim. He's going to start.
Yeah, so I can certainly, I'll just start and be very brief. So, we'll go back to slide. We're ahead. Okay, so thank you. Well, welcome everyone. My name is Jim Scully. I'm a physician scientist here at U of T, and I work with Dr. Fareed Mahmood at SickKids and Allison Dart at University of Manitoba. And you'll hear from all three of us, including some patient representatives from each of our groups. My job is really very briefly to provide an overview of where our program sits in CanSOLVE. Next slide, please. This represents the three research themes that emerged in the dialogue and final creation of the CanSOLVE network. There are three experimental research themes. The first is to identify kidney disease earlier and support those at highest risk. The second is to define best treatments. And the third is to find optimal ways of delivering patient care. Our combined research programs based in Toronto and Winnipeg are focusing on adolescent diabetes, and we're within theme 1. Next slide, please. And theme 1 is, again, to identify kidney disease earlier and support those who are at greatest risk of negative outcomes. And our project is listed as Project 1.1A, and our goal is to define chronic kidney disease risk in youth with diabetes. That includes both type 1 and type 2 projects. Next slide, please. In order to embark on this research program, we realized that there were two initiatives in Canada that shared many features. Each was focused on the identification of kidney risk. The AdDIT trial, which you'll hear about from Fareed Mahmood, focuses on youth in Canada and type 1 diabetes. And the iCARE research group centered at the University of Manitoba and led by Allison Dart focuses on type 2 diabetes, and this is also in an adolescent population. The AdDIT trial has international collaborations in the UK and Australia, and the iCARE trial, although primarily based in Manitoba and northwestern Ontario, has established a network that stretches from British Columbia to Nova Scotia. Next slide, please. And so now we'd like to move on to Dr. Fareed Mahmood, who will describe the youth with diabetes and then focus on the AdDIT component of our research program. Fareed.
Fareed, is it possible your microphone is muted?
Fareed, are you there now?
Yeah, can you hear me?
Yes.
Can you hear me now?
We can hear you and see you.
Okay, I know I look like I'm in a phone center somewhere exotic, but I'm just in Toronto. But I was just mentioning that Megan, who is one of our patient and family advisory council chairs, I notice isn't on the meeting as yet. I know she was finishing up one of her shifts at the hospital, so I hope she can maybe join us later and also share her insights. But, you know, in the interest of time, maybe I can just get started. I wanted to speak about AdDIT, and, you know, AdDIT is the sort of adolescent diabetes cardio-renal intervention trial, and it's focused primarily, we're looking at an adolescent or teenage type 1 diabetes population, and we're specifically sort of focusing in on kidney and heart disease. And you know, we have this we're sharing a little bit of some of our promotional material that we give out to some of our teenagers who participate in the trial, and this is the logo on our T-shirt which says "Keep at it." Again, pardon the pun, but also sharing some of the multinational nature of this, which includes Canada, United Kingdom, and Australia, as well as some of the input from one of our sort of major sponsors, which is the Juvenile Diabetes Research Foundation, which has given us a lot of support over the trial. Next slide, please. I think I sort of described a little bit about the name, but specifically this is a research project which is targeting adolescents. And the scientific basis for this derives from the fact that puberty is one of those very important periods whereby we have sort of significant issues related to the onset and progression of diabetes-related kidney disease. And as such, focusing on, an at-risk period in an at-risk population, in this case type 1 diabetes, formed a large part of the reasons why this trial was initially designed. And, we're going to go through, or what I'd like to go through is to go through the two main study arms. So AdDIT basically went through a screening phase whereby we screened a large group of patients, in the 3 countries, looking at microalbumin, or levels of the protein albumin, which is found in the urine at screening. And on the basis of where patients, had levels, although they're in the normal range, if they're in the upper 1/3 of the normal range, they're eligible for a medication trial. And if they were in the lower 2/3 of the normal range in terms of microalbumin excretion, they're in the observational trial. And these icons are meant to sort of represent our outcomes, looking at evaluating cardiovascular disease, renal disease, in addition to diabetes-related eye disease. Next slide, please. And so the medication trial looked at patients who were, albeit at higher risk, and looked at 2 medications. And these are well-known medications in the adult literature. The first is quinapril, again, an ACE inhibitor, which lowers blood pressure. And the other is atorvastatin, which is a cholesterol-lowering medication. And the study design essentially looked at these 2 medications, either alone or in combination versus placebo, in a double-blinded placebo-controlled trial, evaluating complications related to heart and kidney disease over a 4-year period in the patients who are part of the medication trial. And I'm happy to entertain questions if there are any, just related to some of the study design and other features. Next slide. The observational trial did not include the use of medications, but looked at the natural history of similar outcomes related to cardiovascular disease and early markers of renal disease in this group as well, trying to sort of move forward. Again, sort of shown here with this lovely bottle of amber liquid, showing again the relationship to microalbuminuria and renal function. Next slide, please. So in terms of timelines, the initial medication phase where we underwent the treatment phase of the AdDIT trial has been completed. And the key outcomes that, were the pieces that were studied as part of this trial included, again, how patients manage their diabetes in looking at, a diabetes control number, in this case, the hemoglobin A1C. There were numerous tests related to kidney function, such as albumin-creatinine ratios. There are also numerous very broadly based tests of cardiac function. And these were surrogate markers of cardiac function, including stiffness of the vessels, heart function, in addition to how the vessels react to changes in blood pressure. We also looked at blood pressure and cholesterol levels. And this trial was actually quite innovative in terms of adherence for the medications, as it used a sort of a novel technology which used actually track caps, so that there were microchips embedded in the pill bottles. So we were able to assess every time that the pill bottles were open, in addition to pill counts, to further assess adherence with the medication. If we could take the next icon, that would be great. The observational trial looked at very similar outcomes, again, without the use of an intervention, and also looked at diabetic retinopathy, and that was done in both trials, both arms of the trial. If we could get the next icon. So the next step was sort of follow-up of these study participants, and this is sort of the main theme of our participation in CanSOLVE and in partnership with iCARE, was to further follow up this large group of very well-characterized patients, some of whom had received a medication intervention, others who had gone through an observational phase, and in order to follow them longitudinally to further assess the impact of this intervention and the natural history in this adolescent cohort. Next slide, please. So in terms of the general overview of the follow-up study, again, is looking at a prevention model. What can we be looking at in terms of preventing the onset and progression of renal disease and early cardiovascular markers in these young folks with type 1 diabetes. Next, please. So the question being, did the added study medications help to protect against future incidence of kidney and heart disease, and looking at the 5-year follow-up of these medications and their role as the outcomes are still being evaluated. Next, please. And also looking specifically at the role of inflammation. And we have actually characterized this cohort in terms of baseline and some of the early, information related to the study group, looking at, specific molecules. Some of them are called cytokines or chemokines, and these are related to inflammation in the kidney and in the vessels. And we know that from, prior studies and prior populations that these medications can reduce, the role of inflammation and can be protective. And the question being, is this adolescent group a potential intervention group for use of these medications early on? And if we can have the next piece of the slide, and also looking at, a prediction model for us to be able to understand what are the risk factors when we're looking at specific outcomes for chronic kidney disease and diabetes-related kidney disease. Next slide, please. It's also important that we've also looked at this group quite intensively, looking at social factors, and also, in partnership with iCARE, also trying to align psychological evaluations in these groups to sort of further understand the impact. I think we all recognize this is a very young, vibrant group of people who have their whole life ahead of them, and it's important to understand both their medical histories, but also to understand the stressors in their lives, and to be able to sort of understand the impact of other factors such as the social determinants of health, which we have also looked at as risk factors. And, and this is what Megan was wanting to actually expand a little bit more, that we have established, and, have, I think, a good partnership with our co-chairs and our Patient and Family Advisory Council, and certainly our patient partners are, have been a really great resource for us and a great partner for us to sort of asking the right questions, and also providing their experience, asking the question of what was their experience in the trial, what went right, what went wrong, and also what they would like us to evaluate in terms of the follow-up is very informative for us. And also they've provided us a lot of feedback as to what outcomes are of interest, how we measure them, and what are the correct instruments in order to do that. This is a little bit focusing in on our patient engagement piece. The initial piece was done, I think, last year in 2016, where we again looked at getting a focus group, and we sort of again asked a large number of patients and research participants in order to come back. And I think we can go through this whole thing moving forward. And then, that was sort of went through 30 partitions. So again, looking at an adolescent group, we focus in on patients who are teenagers. We've also asked for assistance, and we have a co-chair who's a parent of a child who's gone through the study. And we also have asked for feedback from people who are young adults who have graduated from the study and now who are in adult care, in order to gain a perspective from all three of these, I think, important stakeholder groups. The meeting was, very helpful for us, and we had, I think, well over 100 people attend, and then we were able to sort of move through the process of people who were willing to, donate their time and their talent to help us out, moving through the process. We've moved forward with conference calls in addition to further meetings, and they've also shared feedback related to what we're asking for in terms of the social factors and psychological factors. And, they'll also sort of help us, I think, with a knowledge translation piece, because as a trial, which is now at the results reporting phase for their first phase, we also need their help in terms of dissemination of the results, and also their help in how we can make the results of the trial relevant to them. In terms of the follow-up study, we're looking at, now we are recruiting the group quite actively, which is sort of the next phase, and also we'll be looking at further analysis of lipid levels and fats and further tests of kidney function, tests of diabetes control, in addition to markers of inflammation as we've described, and also exploratory analysis with our partners at UHN and elsewhere. And also looking for urine samples, looking at the evaluation of the proteome and looking at other metabolome. And we've also looked at measures of further, the ACE and angiotensin system. And we're also looking at blood pressure monitoring, echocardiogram, and some of these very specific tests related to vascular function that I think I've also just described as well as the questionnaires as we've worked through all of these with our patient partners. In terms of where we are, our protocol has been it is completed. It has been submitted, I think, for further evaluation to the CanSOLVE research group. We have a science review, which is required by our institution in order to move forward to assess for scientific validity, and that is also going to be done in the next week. And then we have an ethics board submission, which will also be done thereafter, and then we'll start active recruitment from our subjects, moving forward. And our key function is, the results from the main trial have been submitted and, will be disseminated very soon. And we, again, have a plan in place through our institution and also through, I think, the CanSOLVE partnership in order to look at outcomes and the knowledge translation piece, which for us is very exciting to be able to share the results of this kind of a landmark trial and this very important follow-up with our patients and our partners. I don't know if people have any questions regarding AdDIT, or else we can do it all at the end.
Allison, maybe should we do it at the end?
Sure.
Questions?
Yeah.
Thank you, Dr. Mahmood.
Okay. Thanks very much. So Jackie and I will be presenting iCARE portion of this collaboration. iCARE
Allison, I know you're not normally a quiet person, and it might be on my end, but I wonder if you could get the mic a bit closer to you.
Okay, can you hear me better now?
Yes.
Okay, thanks. So our research group here in Manitoba has a special interest in youth onset type 2 diabetes, which historically was an adult disease, but unfortunately is now more and more common in children. And the pediatric clinic here follows about 300 children now with type 2 diabetes. And every week there's a new case of childhood onset type 2 diabetes. So it's a growing concern in our province, and that's why it's in the focus of our research group. You can move on to the next slide. Unfortunately, the outcomes are significantly worse in children with type 2 diabetes as compared with children with type 1 diabetes. When we follow them long term, about 50% of these children end up on dialysis in their mid-30s. So there seems to be something very different about this disease as compared with type 1 diabetes. And so this collaboration with AdDIT is very important because we're able to compare clinical features as well as biomarkers between the two different types of diabetes to actually figure out which children are at highest risk and why they're at highest risk, and potentially this will lead to new treatments for the highest risk kids. So we've been fortunate to work with our patient and parent advisory group now for coming on 2 years, and we actually developed our initial protocol with the advisory group as a key stakeholder. And the overall study aim that we came up with was a very broad approach to risk evaluation called a biopsychosocial approach. And this was based on feedback from our advisory group, which was that mental health was a very important determinant of health in children with diabetes. And so we wanted to integrate traditional biological exposures as well as psychological exposures, and a broad focus on what the determinants of poor biological outcomes and poor mental health are from the family and community perspective. And our hypothesis is that inflammation is a common pathway through which these risk factors act on the kidney. And as Dr. Mahmoud was talking about cytokines and inflammation, this is also a very key part of our hypothesis in our study framework. Next slide, please. So here's a picture of our patient and parent advisory group. The members have changed slightly over the years, and we're in the process of recruiting new members. But this was our initial patient group, and Jackie is in the center there at the back, and she's been elected one of our chairs. She's our parent co-chair. You can get to the next slide. And so I'm going to turn it over to Jackie to talk a little bit about our group, how she got involved, and what they've been working on.
Hello, everybody. First of all, just give some background information on myself. I am from Capital First Nation. My son, at the age of 12, was diagnosed as being type 2, and that was one of the youngest people ever in our community to be diagnosed at that time. I come from a long line of diabetics. My grandmother was diabetic, my mother is diabetic, my son is diabetic, and now I am diabetic. Type 2 diabetes is very important to me, and I'm very passionate about discussing type 2 diabetes with anybody who will listen to me, actually. So much so, and this is funny and you may laugh, is that I do make referrals to certain doctors because you want to go to a doctor who understands and is not just going to be pushing pills on you and, you know, just giving you a prescription and not really listening and asking specific questions. So I know that much about diabetes. So back in November of this past year, I believe, or was it the summer, we decided we were going to have a co-chair. So I'm the parent one, and we have a youth representative as well. When we first established our parental patient group, one of the very first things that we noticed was we talked about feeling safe with each other and being able to express our emotions. Our first couple of meetings, there was a lot of tears on both sides. It was a chance for us to share our experiences as parents of children who are diabetic, as well as being diabetic ourselves. Our group is multicultural, but there's a majority of First Nations who sit on the committee at this point in time, because there is a large amount of adolescents in Manitoba with type 2. We meet about 4 times a year, and right now we're in the process of trying to recruit new members. The people that were initially asked to join the group were they were recommended. So, you know, they came and things have changed in their life, and maybe they don't think that they can offer much valuable feedback, I'll say. So we're looking at having some new members join, and we're going to be talking about that tomorrow at our next meeting. The thing that Allison had mentioned about the mental health aspect, and we talked about this in our patient group, where we talked about the mental health aspect of type 2 or having type 2, that was almost as important as the medication itself, and that it was lacking. So if we have more discussion and more focus maybe on the mental health side of it, that maybe we won't see as many long-term effects. The biggest one for myself that I had learned was about the high percentage of type 2 adolescents who, by the time they're 30 or in the mid-30s, they're going to be on dialysis, because that really hit home for me because of my son. And he being my firstborn, you know, you really get the full impact of how their life can be shortened if they don't look after themselves. So, yeah, I was very disturbed when I heard that, and I still think about that today. And because nobody wants to see their children go before for you as parents. Yeah, so I don't know what else to say. Yeah.
Story with us. Jackie has a lot of great questions and a lot of great ideas, and we've been very fortunate to work with her over the last couple of years. So, the advisory group was really critical to ensure that mental health was a component throughout, and they gave us a lot of feedback about the measures that we used to help us decide which ones we should be using and what was appropriate. They presented at our local research days, and one of their first projects was to make a video to dispel some of the myths about type 2 diabetes. And if we have time at the end, we hope to show that, or we can send the link around so that people can see this, all the hard work that they've put in.
Make sure you watch it.
Okay, so this is just to show that the voices of our advisory groups were incorporated into some of the questionnaires and some of the data that we are collecting, including measures of social support, quality of life, measures of resiliency, food security, as well as community factors. And these are all based on our initial meetings with our group. Next slide, please. So just as far as a general overview, you'll see that it very much mirrors what Dr. Mahmood presented, and you can put all of these up. They're really the same icons, and a lot of the work that we've been doing is to try and make sure that our protocols are matched and similar, and that we are collecting the same things, or many of the same things between the two cohorts, so that when it comes time to analyze results over the next number of years, that we have all of the same measures available between the two cohorts. And mental health will be a factor as psychological factors, as well as a number of biological factors. Next slide, please. So this is really very similar to what you've seen already from the AdDIT study. Some significant differences are in the number of children that we're able to recruit with type 2 diabetes and where we're recruiting them from. Our goal is to recruit 400 children across Canada, and then to do a 2-year follow-up on the 400 children. We have about 200 recruited already here in Manitoba that are from all over the province as well as Northwestern Ontario. And then we're in the process of expanding to 8 sites, and that's really been a lot of the work over the last year, is to get the contracts and REBs in place at the 8 sites, and Toronto is one of the sites, as well as 7 other sites. And this protocol really matches the AdDIT protocol, so I won't go through that again, but just to point out that we are collecting measures of both renal health and cardiovascular health between the 2 studies, as well as significant data on psychological and social stressors. Next slide, please. The real benefit of this collaboration within CanSOLVE is the ability to analyze our samples that we've been collecting on kids from both cohorts. We have both blood and urine stored and frozen, and we'll be continuing to collect blood and urine as we continue to recruit patients. And we now have the opportunity to bring in collaborators with expertise in different analyses that we didn't have that relationship developed previously. And we can compare things like inflammatory biomarkers, proteins, metabolites, microparticles between the different types of diabetes to see which children or which biomarkers predict worse outcomes, and if there are significant differences between type 1 and type 2 diabetes patients. Next slide. So where we're at is we have also submitted our protocol for scientific review. We have started the contract process, as we did have a bit of a head start with iCARE because we had funding from CHR from last year. So we are almost ready in many sites. We have 6 out of 8 REBs approved, 4 out of 8 contracts approved, and subcontracts in process as well. And we continue to collaborate with our local patient parent group, and work over time will be to figure out how we can involve patients and partners from other provinces as well. Next slide. So this is a place where we could pause for the video if there is time. I don't know, Braden, what you think, or if we should send the link around. It's about 5 minutes.
And as long as we have 15 minutes or so for questions at the end, I think that would be great.
Okay, then let's go ahead with the video. Are people hearing sound?
I don't think it's coming through.
You should make better choices.
Oh, there it is. Okay. Okay, thanks.
Stop eating candy.
You should make better choices. Stop eating candy. It's your fault because you're like this.
It's your fault.
Stop eating candy.
Stop eating so much
It's your
candy.
fault you're like this.
I'm sorry.
You should make better choices. It's your fault. It's your fault. Sorry.
People who follow their treatment plan never have these problems.
You're not taking your health seriously.
You're not taking your health seriously.
You're not taking your health seriously.
I'm sorry.
I'm sorry.
I'm sorry. It's your fault.
I have diabetes. I was told this at a young age.
I have diabetes. I was told this at a young age.
I have diabetes. I was told this at a young age.
Even though many people in my family have diabetes.
I didn't know I could get it at my age.
Every day I worry about taking my insulin or if I've eaten the wrong foods.
We know what we should be eating, but it's hard when healthy food costs so much. Where I live, healthy food costs a lot. I could buy a box of noodles for half the price of a bag of apples.
When your family lives on a fixed income, you need to make your food last. Sometimes the healthy choice is not an option.
It's hard to hang out with my friends and always have to watch what I eat. Can you imagine being a teenager and always making the healthy choice? It's hard to do when all the choices are really bad ones.
Type 2 diabetes is also considered to be preventable. This, however, is not always the case.
If I eat healthy and watch my blood sugar carefully, I may still have high blood sugar readings and need more insulin. It doesn't mean I don't care or that I'm not taking care of myself.
Genetics and biology play a big role in childhood onset type 2 diabetes. Even if I eat healthy and exercise a lot, I may still develop type 2 diabetes. And it's still not my fault. Everywhere I look, I see someone I know living with complications from type 2 diabetes. It's scary, but it's also manageable if I take charge of my health and do what I can. I can live a healthier life. It's not our fault. The iCARE Advisory Group is part of a study to find out the most important risk factors for kidney disease.
Our involvement makes sure that the factors most relevant to us are included in the study.
And could help lead to new treatments in the future.
We need compassion, not judgment.
We need to stop blaming and start asking questions that matter.
Look past the stigma.
Look past the stigma.
Look past the stigma. I don't have to die from this disease.
Okay, so that takes us to the end of the formal part of this presentation. We've gone through both the AdDIT and the iCARE studies and how we are developing a new collaboration with this new CanSOLVE funding. Please go to the next slide. So we just wanted to show you a little bit more about where we are located geographically and how wide the network is across the country. So this, you can just scroll through a few animations. So we now have 9 sites for iCARE, and keep going. And the AdDIT study is really based in Canada, in the Toronto general area. But as Dr. Mahmoud mentioned, keep going. There is a collaboration as well with the UK and Australia. And keep going. And then with, go back on my side, it's not animating very well. We've also developed collaborations on the basic science side in Toronto with peptidomics, in Ottawa with angiotensin analyses and microparticle analyses, also in Toronto for cytokine analyses and for metabolomics at the University of Alberta and University of British Columbia, and you can see the names of our collaborators there. Next slide. So at this point, we'd be happy to answer any questions.
I can just start. Allison and Jackie, you're working with the Indigenous population, which has such a high risk of diabetes, and I know that you've done some work screening in Indigenous communities and in remote parts of Manitoba. Is that where you hope to recruit a lot of patients from? And maybe you can tell us about some of the challenges, like geographical, and that you've face when working with this important group?
So when we talked about the recruitment, like I'm from southwestern Manitoba, so you know, I can easily drive in. Some of the issues we have is like there's type 2 diabetes in northern Manitoba, and transportation is not always easy or readily available. Come down when we have our meetings, but it's important that they have representatives as well as those that are in the south.
Yeah, it's an important challenge because we want to make sure that we're not just representing people from the urban centers. We want to make sure we're representing from rural centers. As far as treatment of type 2 diabetes in our province, most children are referred to Winnipeg for care. They see the pediatric endocrinology group here at the hospital. And so most of our recruitment for patients that participate as research participants has been through that clinic. Now some of them are followed in outreach, and we have gone up north 3 times to recruit patients where they do outreach clinics and follow them up. People move around a lot as well, which is an additional challenge. It's going to be different province to province. Most of the time, pediatric care is out of the tertiary care center. So we're hoping to be able to recruit a significant proportion of children this way. We're going to be missing some for sure that aren't referred to tertiary care centers, but the standard of care at this point is they are referred, not management.
Thank you, Allison and Jackie. To open up to questions online, you can either speak or put your hand up. Well, I have several. I see Chantel on the line. She may have questions. Can you tell me a bit more about maybe mental health and where you think we'll be in 3 or 4 years? Like, you're getting actually a very large population of patients together. Are you starting to think about some things you might test, strategies to help overcome some of these clear issues around stigma and things that people face, children face?
Yeah, do you want to check? I'll say a little bit about the mental health part of it. My son is no longer in the Adolescent program. He's over 18 already. But one of the things that I noticed when he was in there, I thought was important was that parents needed to come together and the adolescents or the teenagers come together, and they needed to be able to share in a safe environment concerns and problems and issues that they face, you know, having diabetes being a caregiver. And at that point in time, that wasn't happening in the clinic, but I believe they are starting to do some of that now. I see changes like that already.
Yeah, we noticed that the patients and parents really gained a lot of value from being together in a room and being able to share their experiences, because they previously felt alone and they were the only ones living with non-face-based. So we now have started a combined clinic with endocrinology for patients that have kidney disease. About 30% of our have proteinuria. And so we follow those patients in a multidisciplinary clinic where there is a group component. And we screen them for depression and anxiety clinic. And we hope to develop a therapeutic relationship with them in that group setting so they can share with each other their experiences. And we're working to get mental health workers in the clinic to help support them. At this point, if they're at very high risk, we've been referring them to psychiatry. Many of them are on antidepressants now, and it seems to be helping in some cases. Unfortunately, there's a lot of challenges that we face, and it's not just about taking medication. But at least we're trying to talk about it and to give them a place to share their feelings.
Any other questions online? any, Jim or in Toronto, that these adherence vials you were mentioning sound very interesting. Did you learn anything from using these, or I can only imagine like
What's that? I'm sorry, Braden, that you cut out on that. I apologize.
I think Braden, Jim, I think Braden's talking a little bit about the adherence for the adolescent piece, and Braden, we learned a lot actually. First question is, what do we expect adolescents' adherence to be? And it was interesting to sort of try to understand that, because there's huge variability as to what that number is. If you look across a lot of studies, it tends to settle out around 50%, depending upon whether it's their oral medications or whether they relate to whether it's related to, say, chronic conditions, whether you look at people who complete for infectious diseases versus higher rates perhaps if you have something like HIV. In the context of diabetes, it tends to settle out around 50% for their oral, certainly their insulin, and I'd be interested to know what the experience has been as well for Allison and the Winnipeg team. But that's sort of what the literature suggests. And in AdDIT, we had overall adherence, and it varied a little bit, but it settled out around close to 80%. And we had some centers that were close to 95% for their patients taking, the oral medications in addition to their regular diabetes management with insulin and the like. So it was actually higher than we expected.
It's Mike McCormick here. Were the patients aware that the vials had these devices in them?
Yes, they were aware, and these it's inside it's called RDEX, and it's inside the actual the cap. And every time they came in, it was sort of a tool, and and it was used to sort of our research nurses would download that information and share that with them. And unlike I think some of the the relationships between taking insulin, which is life sustaining, and some of the other things, we wanted them to have good adherence, and it was a way for us to go through it, and a way for us also to speak to the issues regarding adherence and address any challenges, and also find out if there are any particular side effects or other things. So it was meant to be a very open and transparent way for us to sort of talk to them about their medications and how often they took them and what the barriers may have been.
Right.
And, really,
no, I was asking more from the perspective of, do you think the adherence rate was higher because they knew they were being monitored?
Yeah, and
so, like,
there is. Yeah. Sorry, go ahead.
I was just wondering if there was a control group that wasn't monitored, and if there was any self-reporting of adherence in that group.
No, it's a fair question. We all the patients were using the track caps. Yeah.
Okay.
For the trial.
Okay.
Yeah.
Cool. I mean, if it's actually a method to make people take their medications properly, then maybe it's accidentally stumbling onto something, right? Knowing that people are being tracked. Right?
No, I think you're right. Absolutely. Or maybe compared to taking injections, it was a little bit easier for them, perhaps.
Yeah.
Reed, with kids and taking pills, do we know if when they don't take them, is it just that they forget generally, or is it intentional that they want to take them?
I think you're right on both accounts. I mean, these medications were in the clinical research realm, and I think it was emphasized about the potential for benefit of perhaps preventing disease, future disease. But it wasn't like an HIV life-sustaining medication. So in that context, I mean, and realistically, you could always unscrew the cap and you can give it to your dog. I mean, there's always ways to sort of play into the system. But in general, for this, there seemed to be transparency and about that as much as they spoke to us about, and as much as they wanted to share with us.
In our population,
I don't know, Allison, if you have the same sort of experience with some of the medications you're using these days.
Okay, sorry about that. Yeah, adherence is a real issue for our population. Many of our kids have poor glycemic with average blood sugars in the 15% range, or A1C are 12 to 13%. I think a lot of it has this mistrust of the medications and misconceptions about things like insulin, for example. They attribute insulin to on dialysis because their relatives probably started it soon before they had significant complications. And so you have to work hard against those types of misconceptions. And I think there's a lot of denial as well. They don't a lot of the kids haven't experienced their disease, and so they don't want to take meds because that would be acknowledging that they actually have diabetes. So different than type 1 when they actually get very fast. They didn't take their insulin. Many of our kids run insulin, but they don't get sick very fast. It's a slow process, and they can go for a long time without any significant problems. But unfortunately, that prolonged period of hyperglycemia is causing that.
Any last question? I have one about basic science if nobody else has a question, but let's see if there's another question besides the basic science question. Okay, here goes, and this is coming from a non-basic scientist. But when I see, I'm really happy that the two teams are working together. It's going to increase your sample size so much, and it sounds like you're looking at, you're going to be doing some of the same tests. At this point, like, where are we at? Are we fishing for a new marker that identifies people that are going to go on to progress to having kidney or eye disease? Or do you have a panel of things that you really think are probably, you know, one of these 5 things is likely going to tell us, or some preliminary research, and you're looking to try to confirm which one is best? Where are we at? Where are we going to be at in 3 years?
I think there's a panel, so just to answer your question, Braden, I think there is a panel of cytokine and chemokines. So the relationship between diabetes control, and inflammation is well established. The ability to predict outcomes utilizing those measures is I think is not as well defined. So that is really a targeted group. And from our analyses here in different cohorts, we have about 15 cytokine, chemokine analytes that we would like to better assess with respect to their ability to predict outcome. The second part is that we really are targeting a second series of analytes in the renin-angiotensin system, and this relates to our collaboration with the University of Ottawa and Kevin Burns, and really is focusing on at least a couple of more novel aspects of the renin-angiotensin system. So we think that that's a good bet, because we know that in established disease, blockade of the renin-angiotensin system plays a role. Whether there's a signal that emerges early within that system that might help us, and whether in fact that differs between the type 1 and type 2 diabetics, we think is of both biological interest, but potentially of interest with respect to prediction. We have a discovery-based approach, which is based on studying changes in the urine, an analyte in the urine that may reflect injury to a cell in the filter of the kidney, and that's a little bit more advancing, and that's a more novel hypothesis in which we think that perhaps assessing a very early marker of cell injury in the filter of the kidney, where the diabetes first has a functional and structural effect, might be informative, and relating those changes to inflammation is a secondary goal. That, I think, is a little bit, I don't think within 3 years we'll be necessarily able to utilize that in a predictive model, but we'll see. The last 2 approaches, which are based on on the peptidomic and proteomic and metabolomics. Those are discovery-based processes in which we're really trying to gauge whether those measurements and the evolving technology around those measurements will identify, we hope, a short list of analytes that may well be informative, but that's a discovery-based approach at this point.